Good morning, everyone, and welcome to our second annual State of the People Conference. My name is Rama Issa-Ibrahim, and I am the Deputy Public Advocate for Justice, Health, Equity, and Safety here at the Office of the Public Advocate. I'm so excited that we get to kickstart the day with such an important discussion. It's going to be such an eventful day with so many important conversations happening all day long about issues that cover all that has happened in the last year that impacted New Yorkers. And I'm really excited that I get to start the session talking about the one thing that has been impacting us this whole year, which is the pandemic and COVID-19. We know that COVID-19 has exposed and exacerbated inequities that have plagued our systems for far too long. It's been a very arduous year with a lot of loss and grief. Most folks who've been impacted have been Black and Brown, lower income and immigrants, and communities of color who've died at much higher rates. So this is such an important conversation for us. And we have two amazing women who are going to be joining us. And I have the pleasure of introducing our first guest, and that is Sydney Pereira, who is a health and science reporter at the Gothamist and WNYC covering COVID-19 pandemic in New York City. She has covered local news in New York for various publications, including the Gothamist, Patch, Curbed, and The Villager. Her work has also been published in Newsweek, the Miami Herald, and Think Progress. She studied global public health and journalism at New York University, and she currently lives in Brooklyn. Welcome, Sydney. Thank you so much for being here.
Thank you for having me. Hi, how are you? Great. Yes, thank you again for having me. And thanks to everyone who's tuning into this today. It's an important conversation to have. And again, I'm Sydney Pereira, and I'm a journalist for Gothamist and WNYC. I'll be speaking, and I'm about to introduce her. I'll be speaking with Dr. Celine Gounder today. Dr. Gounder is a clinical assistant professor of medicine and infectious diseases at New York University's Grossman School of Medicine. She's an infectious disease expert and specialist. She's also an epidemiologist, which has been really critical to hear from experts in that field over the past year, as we all know. She's spent her career working on and studying infectious diseases around the world, from Ebola to tuberculosis and HIV, and of course now coronavirus, COVID-19. Most recently, she served on the Biden-Harris administration's transition COVID-19 advisory board. She spent her time working and advising the administration on the response to the pandemic. Hi, Dr. Gounder. I'll welcome you now.
It's great to be here. Thank you, Sydney.
Yeah, thank you so much for being here. So I'm going to jump right in, and I want to start with vaccine inequities and racial disparities that we've seen in New York City and obviously across the country as well. In New York City, now with the vaccine campaign, most people who are getting vaccinated are white so far. Black and Latino city residents got about half their share of vaccinations expected for them based on the city's population makeup. That's the data we have. And of course, the data is imperfect and incomplete, but that is what we know now. So I think the first question I have for you is, from a public health perspective, what do city and state officials need to do to alleviate the racial disparities we all know exist and that we're seeing so far in the vaccine rollout?
Yeah, so Sydney, I think about this in sort of three different buckets. You have vaccine supply, you have vaccine distribution, and then you have demand for vaccine. Actually, issues with all of them. It's not one or the other. In terms of supply, that is a problem that very soon will improve. We now have 3 vaccines that have received emergency use authorization from the Food and Drug Administration: the Pfizer and the Moderna vaccines, as well as now the Johnson & Johnson vaccine. The administration should have on hand by this summer 600 million doses of the Pfizer and Moderna vaccines. Those are 2-dose vaccines. So you divide 600 million by 2, you get to 300 million people vaccinated with that supply. And then in addition, Johnson & Johnson, with the help of Merck, another pharmaceutical company, will be producing 100 million doses by the end of May. So that then gets us to 400 million people vaccinated. So that's more than enough to cover the entire US population, where we have 330 million. So I think what you're going to see is a big opening up of supply through April and May. And really by early summer, everybody who wants to get vaccinated will have the option to get vaccinated. So that's sort of the supply front. Distribution is really, how do we get the shots in people's arms? And I think this is where you start to see the inequities come into play. So if you look at, for example, who was prioritized for vaccination early, that was people over 65, that was people who were healthcare workers or working in long-term care facilities and the like. So looking at people over 65, that is a population that does skew whiter. So just that alone means you're going to have a whiter skew in who gets vaccinated. Healthcare workers, depending on which group you look at, but in particular doctors and to some degree nurses as well, also skew whiter. And then if you look at some of the other professions in healthcare and people working in long-term care facilities, that's when you start to really see more communities of color as the workers. So some of that really has to do with how well all of those people were reached out to. As you can imagine, logistically, it is easier if you're working in a hospital for your hospital to vaccinate you than if you are perhaps health aid working out of different people's homes. So some of that is logistical. And I do think big picture, this really speaks to, you can't wait for people to come to you. You need to take vaccines to where people are. And then rolling out further from there, other populations that have been prioritized have been on the basis of other high risk professions. And so hopefully that does start to address some of the inequities through some of those. Where is the vaccine being distributed? That's another key question here. So again, as I alluded to, the big hospital systems have been major distributors, at least in the beginning here. We also have both state and city mass vaccination centers. Those have been located with really an eye to equity. So trying to figure out what are the hardest hit communities, how can we provide vaccine right there in their neighborhood, and to try to make it as easy as possible. And you may also have heard that you have people coming from outside these neighborhoods to get vaccinated. I think that problem, this sort of issue of zip codes and was somebody from the right zip code getting vaccinated, also speaks to some of the problems we've had with underinvestment in public health. So to enforce that kind of system, you need a combination of people and computer systems that will allow you to do that. So, you have to have a computer system that is programmed to say, okay, are you in the right zip code to be getting a vaccination here? Then there's a cost to making a system like that. And do you have people who will then enforce that if somebody shows up at the clinic or at the vaccination site asking to be vaccinated? And that really is challenging because public health workers, they're very apt already. They have really been beaten down over the course of the pandemic, trying to do things like contact tracing or enforce masking and other public health guidance. And people have been, frankly, quite harsh in their resistance, very, very difficult sometimes, not cooperative. And that has made that job really, really hard. And it's a lot of people of color who work in those positions. So you're asking people in those positions to do the policing. That's a tough one. That's why you end up with some of those issues at the vaccination sites. Some of the places you're going to see distributing more vaccine are going to include federally qualified health centers, which are community health centers that tend to be located in communities of color and vulnerable communities, and also retail pharmacies. And pharmacies, your neighborhood drugstore, for the most part, most of the country actually has quite reasonable access. The major area where there are not a lot of retail pharmacies is actually the upper Midwest. But in places like New York City, to find a nearby CVS or Duane Reade is pretty easy. And so that's going to be a major part of how do we get the vaccine distributed more equitably in these neighborhoods. And then finally, as I mentioned, the hesitancy, demand, you could think of it as demand piece. Do people want to get vaccinated? And this really speaks to deeper, more entrenched lack of trust in the system. I mean, the way I think about it is, if the government was not designed for me, if the government has never really been looking out for me all along, why would I trust what the government is providing me now? And same applies to, say, pharmaceutical companies or health systems. And so I think these are very reasonable anxieties that people have about whether they can trust this. And that is something that needs to be addressed both with education, but also looking at those deeper drivers of the lack of trust.
Yeah, that makes a lot of sense. I think the follow-up to that then is Mayor de Blasio has often said that these wrinkles and challenges with distribution, and he said this a lot too when he announced the data on racial disparities. He's said that the wrinkles in the vaccination program would be smoothed out as supplies increase. And he said the city could vaccinate 500,000 people a week with if there were adequate doses. Do you think supplies are the biggest challenge? And are supplies really enough to overcome the barriers and difficulties with actually getting shots in people's arms?
I think it's all of the above. So it's supply, it's distribution, and it's also demand. And you can't really focus only on one and not the others if you truly want to solve the equity challenge. So as I said, earlier, the supply problem is really going to go away in another month or two. But then you really still need to make sure you're getting vaccines to where people are. So it doesn't, if we have plenty of vaccine, if somebody is not able to take time off work to go get vaccinated, I think some of the solutions around that have been to have 24/7 access to vaccination, where they're going to be vaccinating even in the middle of the night. So I think those kinds of solutions are really important, because not everybody can take time off work during the business day. That would mean either losing wages or maybe having to arrange for childcare. And so I think understanding that is really important, that those are very real barriers. For other people, for example, people with disabilities or homebound people with chronic medical conditions or elderly, again, you have to figure out ways to bring the vaccine to them. For some people, they may just not physically be able to go to a clinic. For other people, they may be blind and unable to log into a website to make an appointment. So we need to figure out strategies to reach all of those people as well.
Mm-hmm. Mm-hmm. And it seems now that the Johnson & Johnson vaccine has been authorized for emergency use, and has already begun arriving in New York. We know that shot requires one dose, so it's one appointment to get your vaccine. And it also requires regular refrigeration, which makes storage easier. And I'm wondering if you could tell me a bit about how that newly authorized vaccine could help reaching some of those hard to reach people, like you were saying, with homebound seniors, or just people who have difficulty going to appointments. Is this a big deal?
Yeah, I mean, I think the Johnson & Johnson vaccine, because of some of the things that you mentioned, for example, to be kept as cold as the Pfizer and Moderna vaccines, it certainly makes it easier if you wanted to go out, say, and make home visits and vaccinate people in their home. If you wanted to go to homeless people who are outdoors. Unfortunately, there are many who are not in the shelter system for good reasons, frankly, that they opt out. But if you wanted to be able to go some of those homeless team mobile vans and wanted to vaccinate folks, the Johnson & Johnson would be probably an easier one to use in that setting. So I think that it's nice to have those flexibilities so that you can distribute more easily.
Okay. And one of the number one criticisms I've heard just in speaking to public health experts over the past several months is how the US has had this patchwork approach to the COVID-19 pandemic from the very beginning, with each state having different mask mandates, different levels of restrictions. Now that we're really exactly 1 year out from the pandemic, particularly in New York, how did that patchwork approach impact the course of COVID-19?
I mean, we're still seeing, unfortunately, with the lifting of mask mandates and wide opening of businesses in Texas and Mississippi right now. And that's really unfortunate because we are at a very critical phase in the pandemic right now. After the most recent surge, which was really driven by festivities around Thanksgiving and Christmas and New Year's. So people getting together with family and friends, not always masking, travel, all of that led to a lot of spread over the winter months. And so we're now just coming down on the other side of that. I think it's important to remind people that yes, things are better, but they're not back down to where they were even last summer when things were pretty bad. So, we've made some improvement, but now what we're seeing is cases and hospitalizations are plateauing. So they're not continuing to come down. They're sort of level at this high level. And we're very concerned because where this pattern has been seen in other countries, it's very likely that we're going to see another increase again before too long. And the reason for that is probably a combination of things. One, people are letting up their guard. That's understandable. Everybody's tired. Spring is coming.
Mm-hmm.
It's sort of a psychological thing of wanting to come out of hibernation. And at the same time, we are also seeing the spread of these new, more infectious variants, in particular, this variant out of the UK, which we call, the scientific name is B117. But this UK variant is spreading rapidly in this country. It is quite prevalent here in New York City already. And what makes it really scary is it transmits more easily from person to person. So let's say I had COVID, I would infect more if I had that new variant than if I had the original. In addition, it's also more virulent, which means that for every person who gets this new variant, it's much more likely to cause severe disease and death. And this is what drove the big surge the British saw over the last couple months that led them to implement very strict lockdowns all over again. So I'm concerned because people are letting up their guard at a time when this new variant is spreading. And we may be setting ourselves back. I think we may be creating more pain for ourselves if we could just be a little bit patient, get more people vaccinated, especially the highest risk, really try to get through that group in the next month or two. Then you would be in a much better place to be lifting some of these restrictions, mask mandates and social distancing and indoor business closures. You would be in a much better position. I think, unfortunately, what we're doing now in many parts of the country will draw out that pain.
Mm-hmm. And just yesterday, I know in New York, Governor Cuomo announced there's going to be a certain loosening of restrictions for gatherings, and with more testing, more events are allowed to happen pretty soon in the coming weeks. Do you think the state is ready for that, given cases are lower than their peak, but not as low as you said as last summer? And we're kind of at a crossroads here where we're trying to vaccinate while also dealing with these variants.
Yeah, this is really not the time. This is not the time to be opening up indoor dining or indoor bars or gyms. This is not the time to be having big indoor weddings, to be hosting big gatherings in person. And this is not even necessarily a partisan issue where Republican governors are doing one thing and Democratic governors are doing the other. I think everybody is under pressure from the business community to open things up again. And I think this really speaks to some of the challenges we have in the US compared again to other countries where we don't have social and economic safety nets to really carry people through difficult times like this. And so it then really does become this choice between public health and the economy. And I think the politics of that are really what have created this patchwork from state to state, county to county, is really just how that balance has played out there.
Mm-hmm, mm-hmm. And on the variants, I think so many people hear that word and are not sure how they're supposed to react to that in their own daily lives. You know, in the daily calculus we all do with what are we supposed to do to keep ourselves and our loved ones safe. So, you know, it's normal for viruses to mutate. I think a lot of us know that. But now we're hearing about variants from the UK, the one you mentioned, and South Africa and Brazil. And now researchers have found a new one spreading that's from New York City, a New York City variant, so to speak. Do we know enough about the variants to really understand like which ones are more concerning than others, and what do you think is the most we should really be paying the closest attention to?
Yeah, I think right now the UK variant is the one that is going to create problems most imminently because it is spreading so widely in the US. We anticipate it will be a dominant strain in this country by the end of the month. So we are very likely going to see a surge related to that. So you're going to see more hospitals, more deaths. So I think in the short term, that's the one to be worried about. In the longer term, I really worry about the South Africa and Brazil variant. What makes those different is that people are getting reinfected. So even if they had COVID before, the immunity, whatever immunity they had from that first infection, is not protecting them against reinfection with the new variant. In addition, the vaccines, while still effective, are trending in a direction being less effective. So it's really important for the two-dose vaccines that you get both to make sure you're fully protected, including against the new variants. What I would say is this is really, with the Brazil and South Africa variants, that's really a red flag for researchers, for the pharmaceutical companies to start producing second generation vaccines that would be protective against those strains, particularly given that continue to evolve and mutate and evolve. We need to stay ahead of the virus, not wait until we have a variant that escapes the vaccines completely. So that's what people are very much focused on. I think for the average person, what I would say is the same things that you do to protect yourself against the original COVID will work here. So the masking, the social distancing, sticking to your household bubble, getting vaccinated, all the things we need to be doing both for the original and for these new variant strains.
Mm-hmm. And I actually want to jump to a question that we got from Facebook. I think it's really relevant to what we're talking about with how effective different things are. So a question from Facebook asking about why authorize a vaccine and that's less effective than the Pfizer and Moderna one. This person, I would assume, is referring to the Johnson & Johnson vaccine. Who would want to get that, and who is it going to be targeted towards? People of color. And so I think this person's question, if I'm interpreting the question correctly, is they're worried the Johnson & Johnson vaccine is going to go to more people of color, and it's less effective, shown to be less effective compared to Pfizer and Moderna. But could you walk through, would you be able to respond to that question?
Yeah, so I think unfortunately the effectiveness has been, the stats on that have really been muddied by the lay media. So people who are not doctors, people who are not epidemiologists, people who are not public health experts. And they have tried to create controversy where there really should not be. Mm-hmm. Why do we vaccinate? You know, I think go back to that question. We don't vaccinate for the common cold. We don't vaccinate for the sniffles. We vaccinate to prevent hospitalization and death. So for example, polio, we vaccinate to prevent paralysis. measles. By vaccinating, we prevent pneumonia, we prevent brain infections. It's not to prevent the rash from measles. So I think you have to reframe it in terms of what is it that you're actually trying to prevent and look at those effectiveness numbers. And the good news is that all vaccines, even some that have not yet been approved here or authorized here in the US, all of them in clinical trials have been 100% effective in preventing hospitalization and death. So that's really the only metric that matters here. Now, the other thing I would say about the numbers is the Pfizer and Moderna vaccines were tested very early during the pandemic before we had these variants. And so in some, we actually have more information about the Johnson & Johnson vaccine. They were studied in South Africa, in Latin America, where you had the spread of these new variants. And then we see that these vaccines still remain effective. The Johnson & Johnson vaccines are still effective against hospitalization and death, even in the face of these new variants. So I would not call this by any means an inferior vaccine. It is just as good for what we care about here. And it has some real advantages. It is a one and done shot. You only need one vaccination, not two. In terms of where is it going to be distributed, it is not going to be targeted at communities of color. It is being distributed to the states, like the other two vaccines, on the basis of population, so population numbers. And that's really dictating how many each state gets. Many facilities will probably have more than one vaccine. They two or even three, and you may or may not have an option depending on what the logistics are at that site. But what I would say is this is really not about these are not being targeted at communities of color. Where you may see some greater use of Johnson & Johnson is for especially hard to reach populations, so like migrant workers, farm workers in places like California, for example. You may see more use of the Johnson & Johnson in the homeless, because it's harder to sort of get that person to come back for their second dose, to track them down. But by and large, it's really going to be used in the same places as the other two vaccines.
Mm-hmm, mm-hmm. That's a good point. Yeah, Johnson & Johnson, that particular vaccine is going to be, like you just said, rolled out at the New York State, a couple of the New York State run vaccination sites already. That was an announcement that came this week. And to turn to something we've heard a lot about is vaccine hesitancy, quote unquote. And when the data around racial disparities was released by the city and state here in New York, Mayor de Blasio and Governor Cuomo talked about access challenges as a part of that, but they also looked at hesitancy as a factor. And there are various surveys showing that people of color, Black, Latino, and Asian people are more reluctant or wary of getting the vaccine right away. But these surveys, they don't tell us everything. They're not always representative, and they're not, the ones I've looked at don't necessarily get at the reason and why. And I think that can differ a lot between different people and different communities. Do we know enough about hesitancy and vaccine hesitancy in New York to point to that as a reason for disparities in this campaign?
Yeah, I mean, as I sort of described at the top, that is definitely a factor. I try to use the words vaccine confidence or vaccine undecided as opposed to hesitancy. Unfortunately, even the word hesitancy has gotten a bit of a negative connotation. But I think if you look at the surveys, the couple groups that are most, that have the least confidence in the vaccines are African Americans, Indigenous Americans, rural Americans, and right-wing partisan Americans. And the through line across all those groups is a lack of trust in government. The reasons for that may be different, but that's the through line. And if you think about why Black and Indigenous Americans might be more hesitant than, say, Latino Americans, If you think about who has been enslaved, whose lands have been appropriated, that's really Black and Indigenous Americans. The history of Latinos is different. There are issues there in terms of trust. A lot of that has to do with immigration and needing to register for vaccination. To go back to look at why people don't trust and address that. So yes, I think, forums like this where we answer questions are really important. People want to feel heard. They want to feel like they're valued, which they should. That's completely reasonable. And they should have their questions answered. And I think that's a piece of it. But I think the other piece is understanding that when people feel like the system was never out there for them, like, why do you care about my health all of a sudden now? Why do you care about the health of my community all of a sudden now when you never cared before? I think that's a very reasonable question to be asking. And so that means that we need to be addressing that deeper mistrust. And I think some of that comes down to really investing in the health and well-being of communities of color, not just during COVID. I think it means addressing what makes people healthy. And a lot of that comes down to people just want decent paying jobs so they can support themselves and their families and do the right thing by them. And I think all of those pieces, if you really want to address the distrust in a long-term way, those are the things you need to start to address as well.
Mm-hmm. I see. Yeah. And how, what does the government need to do to regain this trust? There's a historical context here you laid out really, really well. What city, state, and federal government really need to do to regain that trust?
I mean, it's a form of reparations, really. And so, what does that look like? I think that we clearly need a much stronger social and economic safety net where people are not forced to make these very difficult decisions between public health and the economy in a crisis like this, where they can trust that the government will look for them, that they will have food on the table, a roof over their heads, and all of those basic things during crisis and also not during a crisis like this. I think we need to really have, I would say, a big jobs program. And I think public health is a great place to ground that. Over the last decade or so really after the 2008-2009 recession, we lost 50 to 60,000 public health workers across the country. And that was because of cuts in budgets. Yeah. Cuts in budgets. And so people were not hired, people were fired, people who retired were not replaced. And so we come into this pandemic with this massive understaffing, not that public health was ever really well staffed and funded to begin with. And so that to me is an obvious place, like, let's train up, let's hire people from the community to serve their community in public health.
Mm-hmm. And is there an opportunity to do that immediately? And I think it's happening a little bit. We see with the contact tracing effort and just resources to try to do outreach. But I'm wondering if it's there could be more of that, and if it could be really scaled up rapidly.
Yeah, part of President Biden's America Rescue Plan, which is going through Congress now, calls for hiring 100,000 public health workers across the country. That would certainly, account for those we've lost and then add a few more. Researchers have studied, if you really wanted to meet the staffing needs at a reasonable level across the country, it would really mean hiring 250,000 public health workers across the country. I think that, whether it's 100 or 250,000, I think that is an obvious place there. That is part of what the administration wants to fund. Another area is really around clean energy jobs. So some of that would be in manufacturing electric vehicles, for example. Some of that would be in the wind and solar renewables energy industries. You're going to need people to work in those jobs. And I think those are opportunities to create new, good, high-paying jobs for communities of color.
Mm-hmm. And do you see that as a way to prepare for future outbreaks? Just now that we have seen this pandemic happened over the course of the past year, how can those programs you're talking about really help us be better prepared and more equitable in our healthcare systems?
Yeah. I mean, I think one of the reasons public health has been so underinvested is because the philosophy of public health is health equity. It is to address health disparities at a population level. And we are, unfortunately, in this country of this mindset that people deserve whether they have good health or not. And they deserve whether they're able to pay for healthcare, whether they have health insurance or not. And that's simply not true. And historically, there are certain jobs which have been left out of certain safety protections. These were laws that were passed around the Great Depression that left out agricultural workers and domestic workers in particular. And if you think back in the 30s, who was working in agriculture and domestic work? These were the children and grandchildren of former slaves. These were people of color. And so this was a very intentional leaving people out of those protections. So I think that kind of those that need to be addressed to build greater resilience, to protect people from the next pandemic. We need to invest in public health, and that's people, the workforce, but also our laboratory systems, our health tech systems, so the computer systems that allow you to input information and track information. Part of the reason the CDC only has half the data on race and ethnicity for who got vaccinated, for example, it's a problem of these computer systems. You need to put the information in the system, and that feeds up to the CDC. And so these systems need to be designed to do that, and that costs money. So those are things we clearly need to invest in. And I mentioned green jobs earlier. I think what we saw in Texas, for example, is an example of, and this is with the bad weather, where people lost their power, lost running water, or didn't have clean, safe running water. This really speaks to, we need to be prepared in our energy grid as well, for these major crises. So there are so many different levels at which we have underinvested in infrastructure. Public health is a major one, but there are others as well, if we want to be prepared for the next big crisis.
Yeah, in New York, we definitely saw how computer systems and outdated computer systems really impacted how quickly people could get appointments and who was getting appointments. I think we saw that on a city and state level, for sure. I'm going to turn to a couple more questions from people who are watching. So if you are watching, please share questions, and they'll be sent to me, and I'll pick a few, because I think hearing from Dr. Gounder on these questions is I think will be helpful for folks. So someone was responding to what you had said about pharmacies earlier, about how there's a CVS or a Duane Reade or Walgreens or whatever type of pharmacy in all neighborhoods. This person felt the statement was a little bit misleading, and asked, what should people in neighborhoods that have seen large pharmacies close down, or where those pharmacies are not easily accessible?
I mean, what I can tell you is I've seen the data in terms of distance from the nearest CVS or Duane Reade or Walgreens, et cetera, across the country. And there is one within 5 miles of almost every American, except in the upper Midwest. Now, that doesn't mean it's super accessible. If you live in some place like New York City, 5 miles away, maybe farther. And part of the strategy here is not, and I want to be clear, it's not just retail pharmacies. Federally qualified health centers are also a big part of the strategy in terms of distribution. These are community health centers that are also being enlisted and given supply to distribute the vaccine in their communities. Federally qualified health centers, by and large, serve either communities of color or other especially vulnerable communities, perhaps in rural areas. And so that is going to be very much a piece of the strategy here.
Okay. And here is a technical question for people who already have antibodies for COVID-19, which there are a lot of people with antibodies in New York, because we saw some of the highest rates of infection at last spring. So should people with antibodies get vaccinated?
You absolutely should get vaccinated. The natural infection, the immunity you get from natural infection is very unreliable. And we don't know how long it lasts. And in some people, it will be a strong immune response at one time. And some people, it'll be a weak immune response that fades away pretty quickly. And we're not going to go and test everybody and measure to that level of detail. So everybody who has been infected with COVID should absolutely get vaccinated. I think the real debate is with the 2-dose vaccines, so Pfizer and Moderna, do you need 1 or 2 shots of that? And that is an area where it seems like you may be able to get away with just 1 shot, where in a sense, the initial infection functions as a prime, and then the second infection is a booster. But you should definitely get vaccinated regardless.
Mm-hmm. That's a really helpful answer. I hope that helped the person who asked that question. Another person asked, when will the priority list be expanded? So Dr. Gounder, I know you don't work for Governor Cuomo, and Governor Cuomo in New York gets to make that call on when will it be expanded. So I think I'll shift the question slightly to when should that eligibility list be expanded based on what we know about supplies and what we know about how quickly vaccinations are happening with what supplies we have now.
Yeah, I would anticipate you're going to see an expansion in April and then massive expansion in May, just based on supply. The goal is really still going to be the people who are currently priority. They're going to want to vaccinate as many of them as they can, as many of them as wants to be vaccinated, to get them vaccinated before they expand out from there. So it really just depends on how quickly they can meet that goal. But based on how quickly the supply is going to open up, I would anticipate definitely by April, we would see an expansion.
Mm-hmm. That's helpful. Well, Dr. Gounder, we touched on a lot of different topics here. And I think we touched on a lot of, parts of the pandemic, vaccines and inequities, and the pandemic the past year, and your time here is really, really great. I'm going to hand this back to Rama. Thank you for having both of us, Rama.
It's really a pleasure.
Oh, we can't hear you yet, Rama.
Of course I did this, never come off mute. Thank you so much, Sydney, and thank you so much, Dr. Gounder. Really appreciate you taking the time to have such an important conversation with us and for breaking down all the different questions and going into the details of what the future holds for us. So thank you so much again for taking the time. And I just want to let everyone know that the day is not yet over. There are several other panels happening. The one that's happening right after this one is going to be led by my colleague, Jamila Rose, and is on Communities Empowerment, We Rise, Women Focused on Politics and Power. So please do not miss this next panel happening right now at 11:45. Thanks again for tuning in. Thank you, Sydney. Thank you, Dr. Gounder. Really appreciate it. Thank you all for watching.
Bye. Thank you so much.